Assalamu alaikum. Inshallah, within 2 minutes, we will start with Dr. Sultan Askar about anatomy and pathophysiology of mitral valve disease.
Assalamu alaikum.
Assalamu warahmatullah.
You can see my screen?
Yeah, Sultan, just start. Go ahead. Thank you.
Okay. Can I start or should we wait for
Yeah,
this?
please. Yeah, please just start.
Okay, طيب. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Good afternoon, everyone. My name is Sultan Askar, and today, inshallah, I'm going to be presenting anatomy and physiology of mitral valve disease. First of all, we'll talk about the anatomy of the mitral valve, starting with the mitral annulus. The mitral annulus is a poorly defined structure with out-clear ring configuration that anchors the base of the leaflets. It has two major collagenous structures. The right fibrous trigone, which is part of the central body of the heart, is located at the intersection of the membranous septum the tricuspid annulus, and the aortic annulus. It also has, the mitral valve also has a left fibrous trigone, which is located near the aortic annulus under the left coronary, and also the non-coronary cusp. The normal, usually the normal mitral valve area is between 4 to 6 centimeters squared, whereas the normal annular diameter ranges between 5 and 11 centimeters. Here we can see a picture of the relationship between the aortic valve and the mitral valve. You can see here the right fibrous trigone and the left fibrous trigone. As you can see, the right fibrous trigone has a close relationship with the non-coronary leaflet and the membranous septum. As you can see here, the right fibrous trigone is part of the central fibrous body. It contains the atrioventricular node. And the left fibrous trigone, as we said, is in close proximity to the aortic valve. Actually, the aortic, the anterior mitral leaflet is in continuity, fibrous continuity with the aortic valve itself. So the mitral annulus undergoes dynamic area change during the cardiac cycle. It is influenced by the left atrial and the left ventricular contraction, size, and pressure. The size may actually vary between 20 to 40% during the cardiac cycle. The area increases at the beginning of the late systole and continues through isovolumetric relaxation and into diastole, with the maximal area usually occurring in late diastole. This is regarding the expansion or the expansion of the mitral annulus. The decrease in size of the mitral annulus usually happens pre-systolic, and it occurs during atrial contraction before ventricular pressures rise. This component of the area change is smaller when the PR interval is short, and is usually abolished or obliterated if there is atrial fibrillation or ventricular pacing. So the normal human mitral annulus is roughly elliptical in shape, and it is less circular in systole than in diastole, and in the 3D construction, it resembles a saddle shape or a hyperbolic paraboloid. The highest point is the is the furthest from the LV apex, and it is located anteriorly in the middle of the anterior leaflet. It is termed fibrosa in echocardiograph, and usually surgeons refer to it as the anterior saddle horn. Opposite that area in the posterior leaflet, we have the posterior saddle horn. And this anterior saddle horn is actually the highest point of the, as we said, the highest point of the mitral annulus. The lower points are located posterior medially and anterior laterally at the level of the commissures. As you can see here, this is the anterior saddle horn, posterior saddle horn, and the level of the commissures, we have the two lower points of the mitral annulus. Moving on to the leaflets of the mitral valve, the mitral valve has two leaflets: the larger anterior or aortic leaflet with the smaller posterior or mural leaflet. They usually contain 3 scallops and are separated by clefts. The 3 posterior leaflet scallops are termed P1, P2, and P3. Corresponding to them on the opposite side of the anterior leaflet are A1, A2, A3. The free edge of the leaflet is usually termed the bare zone or membranous zone, with the remainder of the leaflet being termed the rough zone. As you can see here, we have the posterior leaflet with 3 scallops, P1, P2, P3, and corresponding to its A1, A2, A3, and we have here the 2 commissures. Moving on, histologically speaking, the structure of the mitral leaflets can be divided into fibrosa, which is a solid collagenous core that is continuous with the chordae tendineae, the spongiosa, which consists of collagen fibers, but it has abundant proteoglycans, elastine, and mixed connective tissue cells, which are on the atrial surface and form the leaflet leading edge. There is also a thin fibroelastic covering of most of the leaflets on the atrial aspect of both leaflets, this surface, the thin fibroelastic covering, is rich in elastin. And on the ventricular side, it is much thicker and also packed with elastin. So in addition to these connective tissue structures, the mitral leaflet contains myocardium, smooth muscle cells, contractile valvular interstitial cells, blood vessels, as well as adrenergic and cholinergic afferent and efferent nerves. The posterior mitral leaflet is attached, as we said, to the thinner chordae tendineae than the anterior leaflet. The anterior leaflet is attached to a fibrous structure as compared to the posterior leaflet, and the motion of the posterior leaflet is restrained by chordae during both systole and diastole. The regions of both leaflets are usually concave towards the left ventricle during systole, but the leaflet shape is complex and the anterior leaflet curvature near the annulus is convex to the left ventricle during systole, which results in which gives it a sigmoid shape. So in regards to leaflet opening and closing, we'll talk first about leaflet opening. Leaflet opening does not start with the free margin. Usually it starts at the center of the leaflet. First of all, the leaflets will flatten and they will become reversed, and the edge, while the edges are still approximated. The leading edge then will move into the left ventricle, as you can see here, like a traveling wave, and the leaflet will straighten. The leaflet edges in the middle of the valve, they will usually separate before the portions closer to the commissure, and the posterior leaflet usually opening occurs about 8 to 40 milliseconds later compared to the anterior leaflet. In regards to valve closure, the valve closure starts with the leaflet bulging towards the atrium as its attachment point to the annulus. The closure rate of the anterior leaflet is almost twice that of the posterior leaflet, ensuring that the arrival of both cusps at the closed position simultaneously, because the anterior leaflet is opened more widely compared to the posterior leaflet. The anterior leaflet actually arrives at the plane of the annulus in a bulged shape, concave to the ventricle, as you can see here in the picture, in the corner, the right one, this one. So, but as the closing movement proceeds and the leaflet ascends towards the atrium, this curvature appears to run through the whole leaflet from the annulus towards the edge in a rolling manner. The leaflet edge is the last part of the leaflet to approach the annular plane. Moving on from the leaflet, we'll talk now about the subvalvular apparatus. There are two major papillary muscles that support the mitral valve, and both of them provide chordae tendineae to each mitral leaflet. The anterolateral papillary muscle usually has one major head and is a more prominent structure. The posterior medial papillary muscle has two or more subheads and is flatter. The vascular supply of the anterolateral is usually from both the LAD and the LCX, whereas the posterior medial papillary muscle is often supplied by the PDA, whether it comes off the RCA or the LCX in case of LCX dominance. So during diastole, the papillary muscles actually form an inflow tract, however, during systole, they create an outflow tract, which later becomes obliterated due to systolic thickening of the papillary muscles, which augments the LV ejection by volume displacement. They contribute, the papillary muscles, to LV chamber volume about 5 to 8% during diastole, but they contribute 15 to 30% during systole. So the anterolateral and posterior medial papillary muscle contract simultaneously and are innervated by both sympathetic and parasympathetic vagal nerves. The posterior medial and anterolateral papillary muscles, they both give rise to chordae tendineae going to both leaflets. We have three types of chordae tendineae: first order chordae, second order chordae, and third order chordae. In total, there are about 25 major chordal trunks which rise from the papillary muscles. Okay, moving on now from the anatomy of the valve, we'll talk about the diseases that affect the mitral valve. We'll start with the mitral stenosis. Usually, when we talk about mitral stenosis, it is usually the result of rheumatic fever, which is usually suffered in childhood or early adulthood. There are other non-rheumatic causes of mitral stenosis, which they include severe mitral or leaflet calcification in the elderly, congenital mitral valve deformities, malignant carcinoid syndromes, neoplasms, LA thrombus formation, endocarditis, vegetation, certain inherited metabolic disorders, and in case of an implanted prosthesis or a previous commissurotomy of the valve. This is the typical fish mouth appearance of the stenotic mitral valve. As you can see here, thickened leaflets and the stenotic mitral valve. So physiologically, mitral stenosis restricts ventricular filling, which raises LA pressure and transvalvular pressure gradient during diastole. The average LA pressure in patients with severe mitral stenosis may be in the range of 15 to 20 millimeters of mercury at rest, with a mean gradient of 10 to 15 millimeters of mercury. A high transvalvular gradient may also be associated with a normal cardiac output. If the cardiac output is low, however, there will only be a modest transvalvular gradient, and symptoms will not appear unless the patient becomes tachycardic, for example, during physical exertion. So mild mitral transvalvular flow depends on cardiac output and heart rate. Any increase in heart rate will decrease the duration of LV filling during diastole, and that will increase the mean transvalvular gradient and LA pressure. This dynamic nature of the transvalvular gradient may become significant and cause symptoms only with exercise or physical exertion in general. However, chronic and progressive stenosis usually accompanied by elevated LA pressures, and that will eventually become reflected on the right heart and will cause right heart failure, pulmonary vascular resistance, and pulmonary hypertension. One complication of having mitral stenosis is the development of atrial fibrillation, which further decreases cardiac output by 20% or even more. Atrial fibrillation with rapid ventricular response in patients with mitral stenosis can lead to acute dyspnea and pulmonary edema. There is a risk of intra-arterial thrombus from stagnant flow within the large chamber, which increases concurrently with the presence of mitral stenosis. So isolated mitral stenosis is associated with LV chamber size that is normal or smaller than normal, with typically low end-diastolic pressure. The cardiac output is usually diminished due to underfilling of the ventricle from inflow obstruction due to the stenosed valve. During exercise, the LV ejection, ejection fraction may increase, but this response is going to be blunted, and stroke volume and cardiac output do not increase to meet the physiologic demand of the patient. In approximately 25 to 50% of patients with severe mitral stenosis, LV systolic dysfunction is present because of associated problems such as mitral regurgitation, aortic valve disease, ischemic heart disease, rheumatic myocarditis, pancreatitis, or even myocardial fibrosis. So in severe chronic mitral stenosis with elevated pulmonary vascular resistance, pulmonary arterial pressure is elevated at rest and can approach systemic pressure with exercise. Pulmonary hypertension develops because of passive transmission of high left atrial pressure, pulmonary venous hypertension, pulmonary arteriolar constriction, and eventually pulmonary vascular obliterative changes. A pulmonary arterial systolic pressure greater than 60 significantly increases the impedance of the right ventricle and can lead to right-sided heart failure and tricuspid insufficiency. Clinically, patients may be asymptomatic for years. However, once symptoms develop, they usually consist of pulmonary venous congestion with low cardiac output. For example, they will have dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, and fatigue. Patients who have symptoms of mitral stenosis for a long time are usually going to be cachectic and are going to be anemic, are going to have hemoptysis, They're going to have signs of heart failure. They will have, they may suffer from acute pulmonary edema. They may also be prone to systemic thromboembolism, which occurs in about 20% of patients with mitral stenosis. And on physical examination, usually there is a presystolic murmur, a loud S1, an early diastolic mitral opening snap, which is heard at the apex, an apical diastolic rumble, and a prominent S2. In regards to chest radiography, usually the size is normal. However, you may notice some left atrial enlargement, which, as you can see here, is this sign of double silhouetting of the cardiac shadow. The red border here, red dotted border, is the left atrial margin, and the blue is the right atrial margin. This is abnormal. If you have a double silhouette, that means there is left atrial enlargement. ECG is not an accurate method of assessing mitral stenosis. However, if there is left atrial enlargement, you may find a biphasic P wave in lead 2 and V1. And in patients with pulmonary hypertension or right ventricular hypertrophy may develop and will be associated with right axis deviation, tall R wave in V1, and secondary ST T wave changes. However, it's not a very reliable method. Echo is the primary diagnostic method for assessing mitral valve pathology and pathophysiology. Usually, there is reduced diastolic exertion of the leaflets, thickening. There will be thickening or calcification of the valvular and subvalvular apparatus. There will be immobility of the posterior leaflet and the doming of the anterior leaflet as typical morphological characteristics of rheumatic mitral valve disease. Here we can see thickening of both leaflets. This is the 3D reconstruction, which also shows thickening of the mitral valve leaflets. TEE is better and can give more details for if you want to visualize valvular pathology, such as the mobility of the valve, thickness, the involvement of the subvalvular apparatus, and the extent of leaflet or commissural calcification. Cardiac MRI is inferior and is infrequently used in assessing mitral stenosis. CT may emerge. Newer technologies may emerge as a choice to evaluate cardiac structure and function. However, their use is still limited. Mostly, we rely on echo. So, regarding post-procedural outcome, approximately 90% of patients, they improve clinically if the valve area is greater than 1.5 centimeters squared without any significant regurgitation. Surgical intervention substantially improves functional capacity and long-term survival of patients with mitral stenosis, with about 67 to 90% of patients alive 10 years after the procedure. Moving on now to mitral regurgitation, we have two types of mitral regurgitation, primary and secondary. Primary regurgitation, mostly we're talking about myxomatous degeneration or degenerative mitral valve disease. When we talk about secondary or functional, we're usually talking about mitral regurgitation that is caused by dilated or non-ischemic cardiomyopathy, ischemic mitral regurgitation. Rheumatic valve disease can cause mitral regurgitation, mitral annular calcification, infective endocarditis, congenital anomalies, endocardial fibrosis, myocarditis, and some collagen vascular disorders may also cause mitral regurgitation. In general, there are four types of structural changes of the mitral valve apparatus that produce regurgitation. Leaflet retraction from fibrosis or calcification, annular dilatation, chordal abnormalities, which includes rupture, elongation, or shortening, or LV systolic dysfunction with or without papillary muscle involvement. Carpentier classified mitral regurg based on leaflet pathology into 3, or we can say 4 subtypes. Type 1 is normal leaflet motion, which can be found in patients who suffer from non-ischemic cardiomyopathy or dilated cardiomyopathy. Type 2 is leaflet prolapse or excessive motion, which can be found in patients who suffer from chordal rupture or elongation. And type 3 is divided into 2 types, 3A and 3B. 3A is restricted leaflet motion and diastole, and this type of dysfunction is usually found in patients with rheumatic mitral regurgitation. Type 3B is restricted motion and systole, which is found in patients with ischemic mitral regurgitation. So we'll talk about myxomatous degeneration, which is known as a floppy mitral valve or a mitral valve prolapse, which is the most common cause of mitral regurg in patients undergoing surgical evaluation in the US. It can be both acquired and congenital, acquired in patients in fibroelastic deficiency in elderly, or it can be a congenital disease such as people with weak fibroelastic connective tissue, such as Barlow's valve in young patients, or it can be associated with connective tissue disorders such as Marfan syndrome. As you can see here, this is a picture of myxomatous or degenerative mitral valve. This here shows a prolapse of the P2 segment of the posterior mitral leaflet. So myxomatous degeneration commonly involves the annulus, resulting in annular thickening or dilatation. Only about 5 to 10% of patients with mitral valve prolapse progress to develop severe mitral regurgitation, and they can remain relatively asymptomatic for many years. The mechanisms accounting for severe mitral regurgitation include annular dilatation and rupture or elongation of the first order chordae, annular dilatation without chordal rupture, chordal rupture without annular dilatation. Moving on now, we'll talk about mitral annular calcification, which is a degenerative disorder that usually is confined to elderly individuals. It appears to be stress-induced phenomenon, can be associated with systemic hypertension, hypertrophic cardiomyopathy, aortic stenosis, and occasionally advanced Barlow disease. There are other predisposing factors such as chronic renal failure or diabetes mellitus. It is found that about 50% of patients with mitral annular calcification have aortic valve calcification, and annular calcification usually causes MR by displacing and immobilizing the mitral leaflets, which prevents their normal systolic coaptation, or it can impair the presystolic sphincteric action of the annulus itself. This is a picture of what mitral annular calcification. Here you can see the calcification on the posterior mitral annulus. Moving on to secondary mitral regurg, functional or secondary mitral regurg is the result of incomplete mitral leaflet coaptation in the setting of LV systolic dysfunction and dilatation with or without annular dilatation. It is associated with long-standing mitral regurgitation caused by severe chronic LV volume overload. Most commonly, the etiology is non-ischemic cardiomyopathy, which is idiopathic. Functional MR occurs in about 40% of patients with heart failure caused by dilated cardiomyopathy. Ischemic MR, which is a subset of functional MR, is becoming appreciated as the population ages and more patients survive acute myocardial infarctions. And in patients who suffer acute myocardial infarction, it occurs about 15% in those with anterior wall involvement, and in 40% in those with inferior wall involvement. The severity of mitral regurgitation is usually related to the size and the area of the LV akinesia or dyskinesia. The pathophysiology can be attributed to changes in the global and regional LV function or geometry, alterations in the mitral annular geometry, abnormal leaflet motion, and malcoaptation. or increased intercapillary distance and papillary muscle lateral displacement and malalignment, leading to apical tethering of leaflets with restricted systolic leaflet motion. So in ischemic mitral regurg, there may be increased mitral annular area, annular stretching, annular flattening. There might also be increased septal lateral annular dimension, which is termed the anterior-posterior axis of the mitral annulus, which is perpendicular to the line of leaflet coaptation. There may also be lateral displacement of the posterior medial papillary muscle. All of these can cause mitral regurg. In acute ischemic mitral regurgitation, there is usually delayed valve closure in early systole and increased leaflet edge separation and lateral displacement of the central scallop of the posterior leaflet. In chronic MR, however, there is apical systolic restriction of the posterior leaflet and posterior leaflet displacement. And the papillary annular distance in the LV long axis remain relatively constant in normal hearts throughout the cardiac cycle. In acute ischemic mitral regurgitation, the distance changes, which reflects repositioning or dislocation of the papillary muscle with respect to the mitral annulus, which may lead to malcoaptation and development of mitral regurg. The process can contribute to apical tenting of the leaflet during systole. There is also an increased mitral annular area and displacement of both papillary muscles away from the septal annulus throughout the ejection and at the end of the systole. Posterior medial papillary muscle tip displacement probably results from failure of the ischemic papillary muscle to shorten during systole, or lengthening of the ischemic papillary muscle over time, or dyskinesia of the wall that subtends the papillary muscle that is dysfunctional. So papillary muscles are particularly susceptible to ischemia, more so the posterior medial, as it is supplied only by the PDA compared to the anterolateral papillary muscle, which is supplied by the LAD and the LCX in about 71% of cases. We are talking now about papillary muscle rupture. So they usually happen more frequently after inferior myocardial infarction, and they can occur between 2 to 7 days after the MI. Without emergency operation, approximately 50 to 70% of patients may die within 24 hours.
1 minute, Sultan, please. Dr. Shadha, please, can you just mute your mic? Dr. Shadha? Yeah, just go ahead, Sultan.
Sure. So in regards to clinical evaluation of patients with mitral regurgitation, if we're talking about primary patients who are asymptomatic or who come with mild symptoms, usually there will be subtle signs of heart failure, which may manifest as fatigue, which is the complaint in about 25 to 40% of patients with mitral valve prolapse. Barlow's syndrome usually includes patients present with chest pain, some palpitations, syncope, and dyspnea, especially in younger patients. So echo, again, is the mainstay of diagnosis of patients with valvular heart disease. Echo identifies abnormalities in leaflet and chordal morphology and function. The Doppler echocardiography permits visualization of the origin, extent, direction, duration, and velocity of disturbed backward flow of the regurgitant volume. TE can reveal additional anatomic pathophysiologic information, which including valvular pathoanatomy, mechanism, origin, direction, timing, and even the severity of the regurgitant leak. Here we have a 3D reconstruction of transthoracic echo, which shows a P2 flail P2 due to a rupture chorda with a regurgitant jet, as you can see in the other picture. Post-procedural outcomes for patients with mitral regurgitation, usually successful mitral surgery, if the surgery is successful, is going to be associated with clinical improvement. There's going to be augmented stroke volume, smaller LV end diastolic volume, and regression of the LV hypertrophy. Correction of mitral regurgitation can preserve LV contractility, particularly in patients with normal preoperative ejection fraction, who have minimal ventricular dilatation and who do not have significant coronary artery disease. On the other hand, if patients present with LV dysfunction preoperatively, improvement in LV systolic function may not necessarily occur after the operation. So patient selection, especially in patients with functional MR, is of paramount importance, really. I believe we're going to have a talk about this later on, inshallah. Yes, so this was my presentation, and thank you very much. And if you have any questions.
Thank you, Dr. Sultan, for this comprehensive presentation. Is there anyone who has a question he can ask to Sultan? Okay, it seems there is no question. So we can, inshallah, start our presentation after 5 minutes with Dr. Rashid. Thank you, Sultan.
Thank you. Thank you.
Dr. Ahmed, you are ready?
Yes, I am.
Yeah, please just go on.
So, Bismillah, Assalamu alaikum. Today, inshallah, I will be speaking about mitral valve replacement.
Ahmed, seems to be there is some issue in we cannot hear your voice. Ahmed, you can hear me, Ahmed?
Can you hear me?
No, there is some issue, Ahmed. Just check the connection.
Okay, just 1 second, please.
I can
Yeah,
hear him
now we can hear you now.
Yeah,
Here now?
Yeah.
yes.
Yeah, so acute mitral regurg caused by disruption of different part of mitral valve apparatus, as an infective endocarditis which cause leaflet perforation or chordal rupture. Also, spontaneous chordal rupture might occur in patients with myxomatous mitral valve disease. And also it can occur with patients who have an acute ST segment elevation myocardial infarction. And usually it's associated with inferior infarction. For chronic secondary MR, mitral leaflet and chordae usually are normal or minimally thick. And in this case, mitral regurg is associated with LV dysfunction caused by coronary artery disease, ischemic secondary MR, or idiopathic myocardial disease, non-ischemic secondary MR. The abnormal and dilated LV cause papillary muscle displacement, in which in turn result in leaflet tethering with associated annular dilation that prevent adequate leaflet coaptation. Also, it may develop because of left atrial dilation and enlargement of mitral annulus, which often occur in patients with atrial fibrillation and cardiomyopathies. This is the Carpentier's functional classification. It's divided into 3 types, type 1, 2, and 3, 3A and B. So for type 1, it's the valvular dysfunction with normal, there is a valvular dysfunction with normal leaflet motion. And the course of leaflet between the systole and diastole has normal amplitude in this type, and the valve regurgitant because of either leaflet perforation or lack of leaflet coaptation as a consequence of annular dilatation. In type 2, valve dysfunction with excess leaflet motion, leaflet prolapse. The motion of one or more leaflet is increased, and the free edge of one or several leaflet override the plane of the orifice during the valve closure. And the hemodynamic consequences is regurgitation, leaflet prolapse of the mitral, maybe due to either chordae or papillary muscle rupture or elongation. In type 3, valve dysfunction with restricted leaflet motion. So either during valve opening and closure in type 3A, leading to valve stenosis and regurgitation, or during valve closure in type 3B, leading to valve regurgitation. So this is again, this schedule will show the different type of the Carpentier classification and its associated lesion or cause. So in type 1, it can be caused due to annular dilatation or leaflet perforation or tear or vegetation. In type 2, chordal rupture or elongation, and in type 3, which is the restricted leaflet motion and restricted opening, either due to commissural fusion or chordal thickening, and restricted closure in case of calcification or ventricular aneurysm or dilatation. So moving to the valve choice, either bioprosthetic or mechanical. This is according to the American Heart Association guidelines 2020. So for patients who require valve replacement, the choice of a prosthetic valve should be based on shared decision-making, taking in consideration that the patient preferences and the patient condition. This is a class 1 indication. So for patients at any age who require replacement, in whom anticoagulation therapy is contraindicated or cannot be followed or managed, so bioprosthetic valve is indicated as a class 1 indication for them. Also, they mentioned factors that impact your decision in choosing the valve. So there are many factors that going in favor with mechanical prosthesis or bioprosthesis. So in case we have patient male who is less than 50 years old, or a patient preference who want to avoid risk of re-intervention, patient with low long-term anticoagulation. So in this case, mechanical prosthesis would be a good option for him. In case we have a patient who is old, more than 65 years of age, and he's having and he is in high risk for long-term anticoagulation, patient who have limited access to the care center and to follow the INR, so bioprosthesis will be better for them. So moving to the indication for mitral valve replacement. So generally speaking, severe symptomatic valve disease is an indication for intervention. So for mitral valve stenosis, in symptomatic patient with the New York Heart Association class 2, 3, or 4 with severe mitral stenosis. So it's class 1 recommendation this is the class 1 recommendation for intervention. In acute mitral regurgitation, mitral valve surgery, preferably a mitral repair, if possible, is life-saving in symptomatic patient with acute severe primary MR. And the severity of acute MR is variable, and some patients with more moderate amount of mitral regurg will develop compensation as the LV dilate, allow for lower filling pressure, and increase the forward cardiac output. Most patients with acute MR require surgical correction for re-establishment of the normal hemodynamics and for relief of symptoms, especially for complete papillary muscle rupture that cause very severe MR, which is poorly tolerated by the patient. For chronic primary mitral regurgitation, it's class 1 indication for them. So in symptomatic patient with severe primary mitral regurgitation, it's recommended, it's class 1 indication for intervention. Also, in asymptomatic patient with severe primary mitral regurg, mitral valve surgery is recommended for them. For chronic primary mitral regurg, the goal of therapy in mitral regurg is to correct it before the onset of LV systolic dysfunction. And the ideal time for mitral valve surgery is when patient LV approach, but not yet reach the parameter that indicates systolic dysfunction, which is left ventricular ejection fraction less than 60% or equal to it, or left ventricular end-systolic dimension more than or equal to 40 millimeter. So if moderate LV dysfunction is already present, so prognosis is worse after mitral valve operation, and further delay, also symptoms are absent, will lead to greater LV dysfunction and still worse prognosis. For chronic secondary mitral regurg, there is no proof that surgical correction of secondary MR is effective in prolonging life, but observational studies and sub-studies of randomized stitch trials suggest that it's wise to address the mitral valve during CABG for severe coronary artery disease when secondary MR is severe. So just quick, moving to the surgical anatomy. Thank you, Dr. Sultan, for the explanation. Just quick review. Mitral valve form the inlet of left ventricle. It consists of two leaflets, anterior and posterior, which are attached directly to the mitral annulus and to the papillary muscle by the chordae tympani. And also we have series of chordae tympani that originate from the fibrous tip of papillary muscle and inserted into inserts into the free edge and under surface of the mitral leaflet. Thereby, this will prevent the prolapse of leaflet into the left atrium during systole and will contribute to the competency of the mitral valve. The annulus of mitral valve is surrounded by many important and vital structures, and it's important during mitral valve operation. Circumflex coronary artery will transverse around the mitral annulus and in the posterior atrioventricular groove. Coronary sinus also run in the more medial segment of the same groove. The atrioventricular node and its artery, usually the branch from the right coronary artery, run a course parallel and close to the annulus of the anterior leaflet of the mitral valve near to the posterior medial commissure. And the remainder of the anterior leaflet annulus will be in continuity with the aortic valve. So again, these relations are important during the mitral valve surgery. So operative technique, the incision, usually the median sternotomy is the mostly used. Also nowadays, the robotic approach with the standard ortho bicaval cannulation. For myocardial preservation, so when satisfactory cardiopulmonary bypass has been established, aorta is cross-clamped and cardioplegic solution is administered into the aortic root. Cardiopulmonary bypass is instituted by placing two right angle cannulas into the superior and inferior vena cava. The cannula is placed directly into superior vena cava above the SA node. The inferior caval cannula is placed at the entrance of the inferior vena cava, low in the right atrium. This insertion site will keep the caval catheters out of the operative field and will maintain excellent bicaval drainage. The arterial cannula is placed in the distal ascending aorta, and retrograde cardioplegia is useful for all valve surgery to protect the ischemic left ventricle. Antegrade cardioplegia is used initially, then augmented by retrograde cardioplegia. This will provide a safer delivery of cardioplegia because when the atrium is retracted during the valve replacement, aortic valve will be distorted and the antegrade cardioplegia will fill the left ventricle due to the aortic regurg. So in case of aortic insufficiency, satisfactory administration of cardioplegic solution into the aortic root can only be accomplished if aortic valve is competent. So if aortic insufficiency present, a direct cardioplegic solution into the left ventricular cavity will cause distension and stretch injury to the myocardium. So this can be prevented by administering the cardioplegic solution using the retrograde technique alone. Exposure of mitral valve. There are many different approaches for entering the left atrium and providing excellent exposure of mitral valve. We have the interatrial groove through the Sanders-Gaertz groove, transatrial groove, also transatrial longitudinal septal approach. For the interatrial groove approach, left atrium is opened with incision just posterior to the interatrial groove. The opening then can be extended inferiorly to the posterior wall of left atrium. So in this step, it's important to take care of your extension of the incision. So upward extension of incision behind the superior vena cava should be avoided because closure may be difficult. And inferior extension to the back of the heart will provide satisfactory exposure of mitral valve in most cases. Also drainage of cardioplegic solution. At least one of caval snares must be loosened during the administration of cardioplegic solution to allow venous return from the coronary sinus to be drained into oxygenator. So if both snares are down, the cardioplegia will distend the right-sided heart. Air embolism. Aorta must be cross-clamped before opening the left atrium to avoid systemic air embolism. Also, retractor injury. This is an important thing because the atrial wall may be friable. So excessive pulling on the retractor may produce shearing tear of the atrial wall edges, thereby will complicate its closure. On many occasions, two small retractors will provide better and safe exposure than a single large one, because the assistant will be able to divert the pulling force from one retractor to another in order to accommodate the surgeon's view. So for transatrial oblique approach, the left atrium is if the left atrium is small, exposure of mitral valve through the interatrial groove may be suboptimal. Also, in preoperative procedures, adhesions may make dissection difficult or hazardous, particularly near the origin of interatrial groove. So oblique transatrial approach will provide an excellent exposure of the mitral valve. So as we can see here in the picture, oblique incision is made on the right superior pulmonary vein. And the opening in the right superior pulmonary vein will be extended obliquely across the right atrial wall. And by gently retracting the atrial wall edges, incision now can be extended across the interatrial septum through the fossa ovalis. So in this step, care must be taken not to overextend the septal incision. So extension of septal incision beyond the anterior limbus of fossa ovalis may divide the mitral valve annulus, making mitral valve replacement insecure. After that, the disease anterior leaflet detached from the annulus between the two commissures. The anterior leaflet is not extensively diseased, an ellipse of tissue is excised, and the rim of leaflet tissue containing primary chordae is reattached to the anterior annulus using bridgeted suture to be used after that for the valve implantation. If leaflet is thick or calcified, it can be divided into 2 or 4 segments depending on the size of the leaflet. So each segment then trimmed to create a button of leaflet tissue with attached chordae. These buttons are reattached to the anterior annulus with valve suture in anatomic manner. And the posterior leaflet, when pliable, can be usually retained completely together with the attached chordae tendoning. Redundant leaflet tissue is folded up into the annulus by placing valve suture through the annulus and bringing them into the edge of bringing them through the edge of the leaflet tissue. Mitral valve leaflet and the subvalvular apparatus are grossly diseased and calcified, must be totally resected, and the diseased leaflet then pulled gently with the heavy suture or forceps to bring their annular attachment into view, so can be resected completely. So in this step, excessive leaflet excision, good margin of leaflet tissue should always be left with the annulus to allow a secure attachment of the suture for subsequent placement of prosthesis. Over-excision of leaflet may leave weak annulus, making the valve replacement insecure. Papillary muscle excision. So only the calcified and diseased chordae should be excised, leaving the fibrous tip of the papillary muscle untouched. removal of excessive amount of papillary muscle may weaken the left ventricular wall, which may result in hematoma and then hematoma within the wall and possible rupture. Also, excessive pulling on the papillary muscle. So never pull the valve tissue excessively. The heart is flaccid, and over pulling of papillary muscle, as we can see here, may tear buttonhole defect through the weak LV wall. So if such catastrophe occur, it must be detected immediately and repaired with a pledgeted suture. PDA is likely to be in close proximity to this type of ventricular wall tear. So care must be taken during the repair. For sizing of mitral orifice, the largest possible prosthesis should be chosen for mitral valve replacement. Sizer introduced sequentially in the annulus until the correct size can be selected. The size shouldn't be too loose or too shouldn't be too loose or too tight. For the technique of suture insertion, so we have 4 techniques, either simple, as we can see here in picture A, or figure of 8 in picture B, or everted pledgeted mattress suture, or ventricular pledgeted mattress suture. These are the commonly used in anchoring the mitral prosthesis. So if the annulus is well defined and strong, simple or figure of 8 suture will be adequate. And if the annulus is degenerative, pledgeted mattress suture will provide an added security. So after you completely place the sutures in the annulus, so sutures will be also passed through the sewing ring of the in horizontal mattress manner of the prosthesis. So when all sutures have been passed through both annulus and the valve sewing ring, prosthesis will be gently lowered into its position, and the sutures will be tied snugly. Any retained or redundant subvalvular apparatus must be pulled above the mitral annulus plane when the sutures are tied to prevent interference with the mechanism of the prosthesis or left ventricular outflow tract, or to prevent causing left ventricular outflow tract obstruction. If excessive retained tissue is present in the left atrium, it may be secured away from the prosthesis sewing ring with the Prolene suture attaching the leaflet tissue to the left atrial wall. These are the possible sites of injury that we talked about it initially. To start with the left circumflex coronary artery, it courses through the atrioventricular groove just outside the posterior mitral annulus. So care must be taken at this site not to injure the LCX artery. Also the coronary sinus. It traverses around the annulus and likely to be encountered in the region of posterior medial commissure. The artery to atrioventricular node it runs parallel to the annulus just above the posterior medial commissure. Also the aortic leaflet being continuous with the anterior leaflet of mitral valve, and can be occasionally incorporated in the mitral valve stitches. So finally, with the atrial closure, so for inter-atrial groove approach, a double-armed suture with Prolene can be used. So for secure closure, the inter-atrial groove tissue should be included for its putter string effect. To ensure adequate hemostasis, As we can see here in the second picture, a bit of tissue beyond the end of incision should be taken before continuing the closure. For transatrial oblique approach, the divided interatrial septum is approximated with the continuous suture of fluoroprotein starting far anterior end of incision and progressing toward the right superior pulmonary vein. And then other suture can be used to close the right atriotomy. The edges of right superior pulmonary vein are then approximated with third suture. So this is my presentation, and thank you for listening.
Thank you, Dr. Ahmed, for your presentation. Is there any question for Dr. Ahmed? Okay, it seems there is no question. We can start with Dr. Sarah for mitral annular calcification. We can start, inshallah, after 5 minutes. Thank you, Dr. Ahmed. دكتورة سارة,
Yes.
are you suitable to start?
Yeah, I am. Inshallah.
Yeah, just go ahead, please.
Okay. Assalamu alaikum
Excuse
warahmatullahi
me,
wabarakatuh.
can I interrupt you for a minute, Dr. Maryam?
Go ahead.
I just want to ask a question to Ahmed about his previous presentation. I didn't attend, unfortunately, the whole presentation. I have clinic, but I came at the part where he was describing the oblique transatrial approach. So I don't know if he went through other approaches. Like, did you guys discuss, because it's more common to do the transatrial, the transeptal, and the extended superior approach. Are you guys familiar with those approaches? Ahmed?
الله يعطيك العافية. أنا اللي تكلمت عنه بس الانتر اتريال جروب والترانس اتريال.
Yeah. So the most common you guys are familiar with اللي هو الواتر Sondergaard, right? Sondergaard اللي هو الانتر اتريال. صحيح. And then you have the transeptal. The one you presented, which is the transatrial oblique approach. I've never seen it, and it's rarely done because it's involved your incision extended into the right superior pulmonary vein. So there's other approaches, which is the transeptal. I mean, you go through the right atrium, and then you'll open the interatrial septum, okay, without touching the pulmonary vein. And basically, you open from the fossa ovalis. So you will identify the fossa ovalis, and then you extend your incision all the way up to the roof of the left atrium. Okay, and then usually it's enough to expose a mitral valve. And if it's not, for in a case very small left atrium, you can extend your incision toward the roof of the left atrium. And we call this is the transatrial or transeptal approach, and the other one is the transatrial extended superior roof approach. So those I've seen them, and you know, in cases, as you mentioned, in a redo surgery, or in case of patient who have, for example, you're intending to do both mitral and tricuspid valve intervention, then if you're opening the right atrium anyway, then you open the transeptal and you do both valve from the same incision. I just want to clarify that because I don't know if Dr. Khoguer is here and he has any experience with those approaches, but I've never seen the oblique incision. I don't think so. The most common one used, if you're gonna use transeptal, it will be the longitudinal incision.
Thank you, Dr. for the clarification.
Dr. Farid, I think his mic is open, but we cannot hear you.
Okay, I just trying to get things here. Can you hear me?
Yeah.
Okay, so this is very common questions, by the way, as a introduction through the exams. For example, when they go through the case, many times they will ask you about the approach to the mitral valve. So you need to know about all the details. Thank you.
Sure, thank you, Dr. Khoguer.
Okay, you can start, Sarah.
Okay, sure. So again, greeting everyone. I'm Sarah Lapoon. Today, inshallah, I'm going to talk about mitral annular calcification. It's going to be supervised by Dr. Ala Azhari from our center, King Abdullah Medical City. So let's inshallah move on now. Okay. So to start with, our table of content will be about anatomy, definition, pathophysiology of MAC, etiology and association, imaging, clinical implication, management will be guided by a literature review, and finally, a small talk about the AP disruption. So as mashallah, my previous colleague has done an amazing job with the anatomy, so I'll be skipping this part for now. I will be coming immediately for the definition. So MAC will be defined simply as a chronic degenerative process in the fiber space of the mitral valve. Primary affects the annulus, more commonly the posterior one. In the pathophysiology of MAC, it's not the mechanism of itself contributing in the formation of MAC is not actually fully understood, but basically a progressive calcium deposition along and beneath the mitral valve annulus follows the C-shaped fiber skeleton of the posterior mitral annulus with the relatively sparing of the base of anterior leaflet, and that sparing of the leaflet commissures and the anterior annulus will be a good distinguished from MAC from the rheumatic mitral disease. With MAC will be contributed to the mitral valve disease through a mechanism of failure of annular systolic contraction resulting in a regurgitation, or a failure of diastolic relaxation will be ended up with the stenosis, and commonly will be a combination of both. So there is a few etiology and association that have a direct interaction with MAC, although the etiology itself or the risk factor is not entirely understood, but it's a multifactorial disease. So the most common cause of or etiology that is associated directly with MAC is the degenerative age-related process. As the age found to be an independent associated factor in mitral annulus classification. In sex-related different, it shows that it's more commonly found in elderly women, and one of the attributed factor could be the calcium deposition that is related to severe bone loss caused by a postmenopausal osteoporosis. Next is the atherosclerosis. So many studies have suggested that MAC and vascular atherosclerosis have a different forms of the same disease, and usually MAC have a huge association with other cardiovascular disease like aortic, carotid, coronary, and peripheral arterial disease. An important factor in MAC is the increase in the mitral valve stress. So a degenerative calcification in the mitral annulus accelerated actually by the increase in the valve stress that will be contributed by the hypertension, aortic stenosis, hypertrophic cardiomyopathy. And with another factor is the abnormal calcium phosphate metabolism. In this calcium phosphate metabolism, it was observed that commonly in patients with CKD as a direct role in the pathogenesis of MAC. Some congenital metabolic disorders may alter the physiology of the mitral valve, increase the mitral valve stress, or have a direct interaction with the collagen degeneration of the annulus of the mitral, like we have an example of the Marfan or Hallard syndrome. Radiation also is one of the etiologies, especially when it's mediastinal radiotherapy. Another association with MAC is the arrhythmia. So patient with MAC have a higher prevalence of AV block, bundle blush block, and interventricular conduction delay. The association is independent of the risk factor regarding beta fibrillation, but the mechanism itself could be multifactorial in the AFib, like may have a direct cause like in the left atrial enlargement and interatrial conduction delay. With the cardiac intervention, so as we will see later on, inshallah, with the literature review, patient have severe calcification in the mitral annulus, they will be a significant challenge to the surgeon who is going for the mitral valve replacement or repair, as it contributes to many factors like in the cardiac, like in AV fracture, AV disruption, and even prevention of the furule. We will see that inshallah in the literature review. One of the most common complications, as we said, the AV disruption and the injury to coronary arteries with the circumflex artery with the patient. Also, cardiovascular death, morbidity, and mortality, as we can see here. This is an article in American Association was published in 2003 titled Mitral Annular Calcification, Predict Cardiovascular Morbidity and Mortality. It was a study called the Franklin Heart Study with a 16 years follow-up. They concluded that for each 1 millimeter increase in MAC, the risk of incident of cardiovascular death cardiovascular death, and all cause of death adjacent of relevant baseline risk factor increased by 9%, 12%, and 9% respectively. And they discussed that the presence of mitral annular calcification predicts the incidence of cardiovascular event, death, and all cause of death. A diagnostic imaging will be help diagnosing the MAC will be starting with echo, the primary imaging modality and the gold standard for identification and characterization of MAC with associated mitral valve disease. Cardiac CT also has a major role in quantify the amount of calcification and the extent of MAC. And finally, the fluoroscopy. Here I have 3 pictures of the same patient. She's a 76 years old female patient. She was going for evaluation for aortic stenosis, where she was discovered an incidental finding of MAC. As you can see in picture A, you can see the shadow in coronary angio. While they're doing coronary angio, they can see the dorsal calcification of the MAC. Later on with the echocardiography, we can see the calcification around the posterior annulus. And in the last picture with the CT in picture C, we can see the calcification, and it was extended up to the LVOT with the black arrows. So let's move on to clinical implication. So usually MAC is an incidental finding in patients being evaluated for cardiovascular and pulmonary disease. But in CT or echocardiography, MAC will be found in up to 8% to 15% of patients without known cardiovascular disease. But the prevalence will be increased up to 42% in patients who is elderly and with a known or coexisting cardiovascular disease. Okay, let's move on to the main part now, the management that will be guided with our literature review. I will start with this study. It was published in the Journal of Thoracic and Cardiovascular Surgery, the current and evolving strategies in the management of severe mitral annular calcification, published in 2018. So the main question that should be asked or to guide our surgical management in MAC is whether to repair or replace the valve and how to address the heavily calcified annulus. You have we have regarding the calcification, we will talk about either resect or resect. In resect procedure, as the name itself, it will not be around. We will be working around the calcification and not actually resecting it as in the resect. So the advantage of resect, it's a simple, shorter procedure. It have a lower risk of the AV groove disruption, but one of the major advantage of the resect is you will not the replacement will be opposed to repair, as there will be no decalcification here. It has a higher chance of paravalvular leak when the suture will be taken around the calcium bar. The risk of injury to the circumflex artery and the paravalvular leak will be higher. And that will be the major disadvantage in the resect procedure. But in resect, you will allow a natural prosthesis size and position, as you already did the decalcification and reconstruction of the annulus. You will be more likely to allow the both procedure as an option, either repair or replacement. There's a less risk of paravalvular leak, as the prosthetic will be there will be no calcium bar that will be taken with the suture. But one of the major disadvantage of the decalcification is the risk of AV groove disruption, as we'll talk about later on. They did this orientation or approach in guiding the surgical management of patient with MAC. So patient that's coming with MAC, they have a higher surgical risk. They will have the 2 options of either medical therapy or transcatheter valve. Patient from mild to moderate surgical risk, and how they have with the leaflet that can be repaired. In the case of severe MAC, you will have a 3 technique that can be used. Either the Carpentier, where you go the figure of 8 directly to the annular closure with or without atrial slide. I will illustrate the picture later on. Or you have the David procedure with the posterior annular pericardial patch, or the Castleman's with the posterior annular augmented by the anterior mitral transit position. In case of leaflet that cannot be repaired and you go for replacement, then you have the option for the transcatheter or the surgical. In case there is a technique that can be used in patients with severe mitral stenosis with less than mild MR, which is the extra anatomic bypass. If not, is that just will do the replacement later. In picture A, we can see here the Carpenter method, as we said. After the decalcification, you will do a figure of 8 suture, either with the atrial slide, as you see in picture B, or without it. In C is the David procedure with dressing the pericardial patch, and use the Kesselman anterior mitral leaflet transposition. This is the extra anatomic or the atrial bypass. It was first published in 1981. They will do a bypass from the left atrial to the apex, going from the right side, with the conduit having a valve in the middle of it, with a high chance of valve thrombosis. So it wasn't there wasn't a lot of study about it, and it's in 2014 there is a case report titled "An Alternate Approach to Valve Replacement in Patients with Mitral Stenosis and Severely Calcified Annulus." So in this case report, there was a lady, 44 years old, end-stage renal disease. She presented with severe AS and severe MS. She was done mechanical prosthetic aortic replacement, and for the mitral, they did the external atrial bypass, but they did a switch from the origin procedure. They did the bypass from the left side, and they didn't put the valve conduit in the middle to decrease the risk of valve thrombosis. They made it as close as they could to the apex. Patient have a good post-operative management. She was discharged from after the 8th day of post-op, but unfortunately we don't have a follow-up for it. And this procedure itself is not that common. It's not commonly used, so not a lot of study about it. Okay. Let's move on to one of the recent study. It was published in 2022. It's titled "Complete Excision of Mitral Annular Calcification that can be achieved with a low mortality risk." So simply in this study, they took a 38 patient they were operated from January 2017 to December 2020 in the setting of significant MAC. 14 patients went for mitral valve repair and 24 for replacement. Both categories, underwent a complete removal of entire calcium bar, followed by a patch reconstruction of the debridement area before either repair or replacement. So the outcome of these patients, 2 patients has died in 30 days mortality, and 4 patients died later on. 1 patient required post-operative extracorporeal support, but they have a good survival at 1 year with 89% and at 2 year, 82%. So they conclude in their study that the excision of the entire calcium bar and annular reconstruction can be used in patients undergoing either isolated or combined complex mitral valve surgery, as this strategy has a relatively low risk of preoperative mortality. This was their illustration of the total calcium decalcification. So let's start with the picture A. So the base of the posterior leaflet of the mitral valve will be incised and deattached from the annulus itself. Then in picture B, the calcium bar will be excised. After that, a piece of pericardium will be used as a patch for the defect in the posterior after the decalcification. Then in picture D, the patch itself will be reinforced and from the ventricular side with a Blodgett suture. After that, a valve suture will be placed, and a prosthetic valve will be parachuted and secured in a standard fashion. So another study published in 2003, mitral valve surgery in patients with extensive calcification of the mitral annulus. They supported the previous one with the decalcification before even deciding for repair replacement. They conclude that severely fibrotic, calcified, and immobile leaflet heavily deforms subvalvular apparatus, calcification of the entire annulus, and/or extremely fragile tissue remain a contraindication for valve repair. If the surgeon is not comfortable with the reconstruction, then it might be safer to partially excise the leaflet and leave enough room to intact to which an adequate size prosthesis can be inserted. A batch reconstruction of the mitral annulus is an extremely useful adjacent to help avoid complication of the atrioventricular disruption or a valve dehiscence. Here, another study titled Mitral Annular Calcification Predict Immediate Result of Percutaneous Transvenous Mitral Commissurectomy, published in 2011. It will be guided by the Wilkins score that has the factor of leaflet mobility, leaflet valve thickening, subvalvular thickening, and valvular calcification with 4 grades for each. So in this study, the percutaneous transvenous mitral commissurectomy became an established procedure of choice for treatment of mitral stenosis. In the selection of patient for PTMC, a favorable Wilkins score less than 8 is highly predict an optimal outcome after the percutaneous commissurectomy, but does not examine the MAC. So in the other study, a 17 patient exhibited echocardiographic evidence of MAC, while the mitral annulus was normal in 70 patients. The rate of optimal PTMC result was significantly lower in patients with MAC than in those with a normal mitral annulus, in 29.4% in patient versus 71.4%. And patients with MAC were still at an increased risk of suboptimal PTMC result. So they conclude that MAC appear to be independently influenced the immediate result of PTMC. Therefore, a mitral annulus evaluation may be considered in the echocardiographic assessment of the mitral apparatus prior to the percutaneous commissurectomy. In 2021, American Heart Association published a systemic review titled Surgical and Transcatheter Mitral Valve Replacement in Mitral Annular Calcification. We'll just go through a very good table for comparing the percutaneous transcatheter mitral valve replacement, transatrial and surgical. So the approach in the percutaneous will be through transseptal or transapical, with the potential advantage as it's less invasive, but it has some limitation as it's highly selective and required and have a risk of LVT obstruction with a polyvalvular leak. And unfortunately, it have a short to immediate follow-up up to 1 year. In the transatrial transcatheter mitral valve replacement, it's a direct approach. It has a very good advantage of reducing the cross clamp and cardiopulmonary bypass time and allowing concomitant cardiac procedure. But it has a limitation of requiring sufficient MAC for the valve puncture. And again, it have a short time follow-up and up to 1 year. So moving on to the last topic I'm going to talk about, which is a direct complication of the mitral valve replacement, the atrioventricular disruption. So simply, the AV disruption is caused by a surgical technique or by a stretch injury due to removal of posterior leaflet and untethering of left ventricle. It appears in about 1.2% of mitral replacement, and the mortality rate is up to 75%. So it's classified into 3 types according to the location of the tear. Type 1 will be ruptured located in the AV groove. Type 2 will be the rupture will be at the base of the posterior papillary muscle, and type 3 will be occurs midway between type 1 and type 2. Each type can be further divided into intraoperative early or a postoperative delayed rupture. AV groove rupture, once it happens, treatment is difficult and it results in high mortality and morbidity. It should be diagnosed immediately and repaired without any hesitation. I have an illustration here that was added in the article. Here we can see in picture A a small tear of AV groove rupture and laceration of the posterior left LV wall. Repair was done by bovine pericardial patch of the AV groove rupture with bloodshed suture, and they do another patch for the LV laceration. So, concluding with the key points, patient with extensive mitral annular calcification who required mitral valve surgery may present a significant challenge to the surgeon. The variety of technique for addressing MAC testify to the complexity of this problem. The decision of whether to remove the calcium bar and then repair or replace the valve to leave the calcium intact in place should be performed individually. Surgical expertise and confidence in the selecting treatment strategy play an important role in the management of patients with mitral annular calcification. So that concludes my presentation. Thank you so much for listening.
Thank you, Dr. Sarah, for your comprehensive presentation. It was a beautiful presentation, actually. If there is any question for Dr. Sarah?
Thank you, Dr. Sarah. Very nice presentation, informative and concise. I'm just wondering regarding the reconstruction with a patch. How safe it is to be done? I've never seen it, honestly. And I don't know, maybe it's difficult the question if one of the consultants attending can answer it. And how safe it is to be done, and is it will it be to expose the circumflex or the how deep you can go with the sutures after you remove the calcification, and transapical. I've seen all of them referred for medical or transapical valves. Thank you again.
Is Dr. Ala here? Can you please, if you have any comment for the question? Or maybe Dr. Farid, if you want.
So I'm not sure if I'm understanding the question correctly, but you're trying to remove calcium and you expose the circumflex artery. Maybe that's the extreme. Anyway, I think it's very important to train yourself how to extract the calcium from the from the annulus, and knowing how far it can go. If it goes too far, it's a lot safer to leave it behind rather than trying to extract it all. Because if you have a disruption or a near disruption, very thin wall at the AV groove, and then you put it in and you try to come off and it's ruptured, that's really a disaster for the patient and maybe for you too. So the way I would ascribe to removing the calcium is using the needle holder itself and crushing pieces of the calcium nodule as a piecemeal, one at a time, and take it away, or just crush and remove and clean. Make sure you don't leave anything behind. So by doing so, the calcium is actually in between the tissue. You still have very good fibrous tissue behind by doing this technique. You may not, but if you do it frequently, you learn. And I think one way to learn how to do this is when you do the animal lab, or you have a specimen in the wet lab, use the needle holder and crush it, crush the ribs, and see how much you can extrude from the ribs, leaving behind some tissues that you can sew. And once you sew those tissues, you can have a feel of how strong is this tissue. Will it hold the valve in place? Now, if you leave some, if you think it's too big and it goes way beyond the annulus, and it's definitely going to expose the artery, the circumflex artery, for example, or you'll be outside the heart in that point, then I would personally try to leave it in, and I use a stronger needle either to go through it or around it with the pledgeted sutures. Now you're stuck there and something bad happened and you can't see clearly you're outside. Use a patch. The pericardial patch, bovine pericardial patch, is a very good material. We have used that before. So you suture it just like a VSD patch on the healthy muscle below the annulus, across the area of the annulus onto the area of the LA. That will, and make sure that it's, of course, sealing the whole area that you're concerned about. And when you put your sutures for the valve, it will be sutures in the pericardium, just like we do, for example, when we do the pulmonary valve insertion. You can see the tissue there, the pericardial patch, and you can go through it with the sutures. I remember one time I operated on somebody who's did not have this, but had actually I'm not sure really what it is, but it looks like almost like a diverticulum or disruption, old disruption, and the whole area was very thinned out behind the circumflex tree and the annulus, behind the annulus into the ventricle. And what I did there is the tissues were good enough, so I put the patch, the pericardial patch, closed that area completely, all the way to the annulus, and my sutures were in the annulus. So, and you just have to play it with heart. By the way, these are difficult cases. If you are asked about it, for example, in the exam, say I will ask for help from my senior colleague. If you are really in real life and you just got out of your residency and you're in real practice, call for help. It will be good for you and good for the team and good for the patient, definitely, to ask for somebody with experience to be joining you. And if somebody asks for your help, please do not hesitate. Thank you.
Thank you, Dr. Farid.
Thank you very much, Dr. Farid. If you will allow me just to add a few points. I just want everybody to recognize how challenging the case is, and always remember, one option is no option. I've seen a lot of MAC cases turned down for surgery, recognizing the high risk of AV dissociation. And if it's happened, it's really difficult to repair. So the other few cases that I've seen with MAC, a patient with mitral regurgitation and plus MAC, no stenosis. So what they did, they only did alveolar stitch. So they did not replace or did anything to the valve itself. And the other severe mitral stenosis and MAC case I attended in Toronto, they did a Sapien valve implantation, direct vision in the OR. So they bought the catheters and everything, and they ballooned the valve and the direct vision. And with regard to the upcoming new technology about the transcatheter mitral valve replacement, I'm not sure if it's FDA approved yet, but I think it's coming. So it will serve this population. Thank you.
Thank you, Dr. Mariam, for the comments.
Is there any more question? Okay, thank you, Dr. Sarah, for your presentation. Dr. Baghaffar and Dr. Shaidan, they apologize for their presentation, so we can finish our session today, inshallah.
Yeah, I'm really sorry. I've just received the last night cancellation from Dr. Baghaffar. Otherwise, I would have, do something or collect some cases for you guys. Inshallah, next week we'll have a session.
Inshallah. Thank you, Dr. Mariam.